Good evening, everybody. Welcome to this webinar where we are today going to discuss interesting cases in abdominal diseases. And today we have a galaxy of panelists and my co-moderator, Dr. Ajay Kumar. Dr. Ajay Kumar is a very, very eminent gastroenterologist. I think he does not need introduction to this particular audience. Next panel we have Dr. Singhal, who is a very eminent physician. He is the chairman of the Department of Internal Medicine at BLK Hospital. Then we have Dr. Bhalla, Group Captain Dr. Bhalla, who is my colleague, my senior colleague. He is the chairman of the Department of Surgical Gastroenterology, Minimal Access and Bariatric Surgery. We work together. And he has been in academics for more than 25 years at AFM. Then we have Dr. Prem, who is a close friend and also chairman of the Department of Radiology. He comes with a lot of experience. We also have Mana, who will be joining us very shortly. He also works in the Department of Gastroenterology in our team. He's a very eminent transplant hepatologist and a very enthusiastic intervention gastroenterologist. He will be joining us shortly. And once again, let me welcome you all and welcome Kritika and his team from the Docplexus for inviting us. So with this, I will start with interesting cases and I will share my screen. Can you see? Is my screen visible, sir?
Yes.
Yep.
Yes, yes.
Okay. So I'm going to start with two cases which are quite similar in presentation, different diagnosis. So case one is a 54-year-old female, 54-year-old female who has a weakness since 7 days, breathlessness in 7 days, history of passing black stool since 5 days, and on investigation she was found to have hemoglobin of 5.4 gram%. She was transfused 6 units of PRBC outside, and with this history she was referred to us. Similarly, another case, 57-year-old lady with almost similar complaints of generalized weakness since 2 days, history of black stools 2 days, and hemoglobin 5.3 with 4 units of blood transfusion from outside. So these two cases were referred to us from outside with this history. Dr. Singhal, what would you like to do next as investigation in these two cases?
Thing is, this is a middle-aged females who have come with generalized weakness, and they obviously because of black stools and fall in hemoglobin, but they are bled in the upper GIT because of the black colored stools. Now the crucial question is, what is the cause of bleeding in the upper GIT? Where it is an ulcer, where there is a variceal bleeding, because they are females, so not very likely to be alcoholic. It could be NASH or something, drug-induced erosive gastritis, something. So we have to see what is the history of drug intake, whether there has been a past history of abdominal pain, and whether there is any vomiting, whether they have passed any blood in the vomiters, how do they present, and whether there has been a past history of jaundice, that we have to be careful.
So we would like to, what we did in this particular case is did an upper GI endoscopy, as Dr. Singhal was suggesting that probably the cause seems to be in upper GI with black color stools, but it was surprisingly normal. What would we like to do next, Dr. Ajay?
See, as you rightly said, that whenever you have a melena, black stool, then 90% of the time are the lesions which are detectable on upper GI. So when it is not there, then obviously we look at the lower part of the bowel. Now, most of those cases will end up in the small bowel, but it will be mostly localized to the terminal small bowel. But the way to go ahead is to do a colonoscopy, which we plan to do with this patient accordingly.
So as Dr. Ajay very rightly suggested, we went ahead with colonoscopy, and in both the cases what we found was fresh blood mixed with stool throughout the colon. But we could not find any definitive cause in the colon or in the terminal ileum to blame for the pathology. Sir?
Hello?
Yes, sir. I think your internet connection is probably not good. Rest of all, can you hear us? Dr. Bhalla, Dr. Prem?
I can't hear anyone.
I can hear you, Deep.
Yes, yes, we are hearing you.
Ajay, I think your internet probably is not.
Dr. Prem.
What you can do, sir, just off your video and let the audio be on. I think it will improve. So, Dr. Balla, sir, since in these two cases upper GI was normal and the colonoscopy shows mixed blood with stool, these are some of the options which are available to us. But what would you exercise as the first option in these cases?
If the upper GI and the lower GI endoscopies are both normal, the cause of the bleeding lies in the small intestine. Now, depending upon the general condition of the patient, if the patient gives us time, then maybe we could do an enteroscopy first. But I think the next investigation which would give us most information is a CT angio study in this patient. A nuclear scan and a capsule endoscopy in an acute setting like this are probably not helpful.
I completely agree. Dr. Prem, would you like to comment? Anything extra or any comments?
In fact, instead of doing a CT angio, I would prefer to do a CT triple phase abdominal study, which will give me, apart from the angiographic phase, also the venous phase.
Right.
So that will add value in patients who have, sometimes the angio may not pick up the bleeding source. So sometimes you can get it in the venous phase. So I would prefer a CT triple phase study in this case.
So what we are saying the same thing, that we will do a CT scan which will show us the vascular anatomy and probably the source of the bleeding. Yes. One can obviously argue and differ whether we want a triphasic or a CT angio. Yeah, but the CT scan seems to be the investigation of choice in these situations, and this is what we did. In the case one, we did a CT angiography, and what we found is sub-centimeter arterial enhancement in the mid-ileum at two places, which were bulging interluminally, and this enhancement was persisting on the venous phase. There was no obvious pooling, and it was suggestive of small bowel angiodysplasia, and this is the picture, if you can see here. Very beautifully, you are able to identify. Dr. Prem, would you like to comment on the picture?
Yeah. You can definitely see the arterial anatomy there. You can see the feeding vessel there, and then you can see a bunch of hyperdense area in the bowel wall, which appears very tortuous and enhancing. So probably this is the source from which the patient is obviously bleeding, and it is very well delineated. So the anatomy, if you can see other images, we can localize where exactly the lesion is, and gives a fair amount of idea for the surgeon or the treating physician to handle this case.
So obviously with this investigation, we were able to find out the cause of the bleed, and we were not, obviously, as Dr. Prem said, that if we had another film here, we would have probably guessed the site of the bleed in a small bowel, but sometimes it is not possible because there's such a large small bowel which we have, and it's a free floating bowel. So what we planned for this, obviously this lady required surgery. We planned diagnostic laparoscopy, and with, if required, intraoperative enteroscopy with resection of the ileum or jejunum wherever the disease was. This was the plan, and then we went ahead with the surgery. We were not able to localize the disease from outside, and that is when we called in for help from a gastroenterology colleague and Dr. Ajay Kumar's team. Somebody came and we did intraoperative enteroscopy. For audience, let me just explain. In intraoperative enteroscopy, we make a small hole in the intestine, small intestine, and we pass our endoscope through this hole, and we go up and down to have a look the entire length of the small intestine. And if you see, under illumination from inside, we are able to see these leash of vessels here, which is the probable cause for the bleed. And as it was also suggested by CT angiography. So we localized it, and we did a limited resection of this area with anastomosis, and patient was cured of the disease. And this is the endoscopic picture of angiodysplasia, as you see here, the spot, and there's a blood in the lumen. So take home message from this particular case is that obscure GI bleed can be challenging to manage, and upper GI and lower GI endoscopy usually do not give the cause, and further investigations, as we had discussed, should be done in consultation with the specialist. Sir, would you, Dr. Bhala, would you say, would you tell the audience that is there any indication of nuclear scan in obscure GI bleed? And if yes, what is the indication?
I think a nuclear scan is probably overrated in such a situation, because even with the current modern dynamic nuclear scans, even if you can pick up, say, evidence of a bleed within the lumen of the intestine, you are not able to localize it. And hence you have to do something ultimately. But
Right.
yes, in certain situations, there used to be a thing that if the rate of bleed is more than 2 ml per minute, then you can pick it up on a nuclear scan. But it just gives you a general idea of where it may lie. And you have to deduct, okay, the pooling is happening in this quadrant of the abdomen, so it's likely to be here.
Dr. Ajay, would you like to comment on how, when would you like to do push enteroscopy and capsule endoscopy in obscure GI bleed, sir?
You see, in a situation like that, we will not like to proceed ahead with push enteroscopy. Our relationship of enteroscopy and a capsule endoscopy is like the relationship between MRCP and ERCP. The capsule endoscopy scans the entire small intestine, and in a patient like this, you do not know which part of the intestine is bleeding. So even if I do push enteroscopy, unless I have a very high index of suspicion in the upper small bowel, other than that, it is not the preferred technology. So what rightly pointed out in the beginning, if the patient is actively bleeding, massive lower GI bleed, then you go ahead with a CT. If patient is bled and settled down, then, and we have time, then we go for capsule endoscopy. I will restrict. And depending upon what capsule endoscopy shows me, I will decide whether I'll go for enteroscopy, which is today's time I will label antegrade or retrograde, depending upon the site of bleeding which is suggested by capsule endoscopy.
Right, sir. Thank you very much. So the impression we are getting from the specialist that if the patient is bleeding and it continues to bleed, do not waste time in doing different investigation. Do an investigation which is likely to give you an answer in terms of site and the nature of the pathology. So you can quickly act and save the patient. But if patient is stable and not actively bleeding, then you have time at your hand to do other different investigations to make sure and find out the site of the bleeding. So for this particular case, what we know is that small bowel vascular malformations are uncommon source of GI bleed. These malformations are more common in the right colon and elderly people. Surgery and peroperative enteroscopy are often complementary to each other to find out the exact site of the bleeding, and they are often required. Coming to the second case where we did a CT angiography, what we found was that a diverticuli at the mesenteric border of the mid-jejunum with mildly increased enhancement and minimal adjacent fat stranding. And this is the picture. If you see here, Dr. Prem, would you like to comment on the film here?
Yeah, there is this diverticulum there. You can make it out, which is anterior to at the end of the third part of the duodenum there, and you can see some amount of free fluid adjacent to that, which is suggestive of probably reactionary fluid out there.
So again, with these findings and with this history, patient were planned for diagnostic laparoscopy, and the possibility, if we are not able to localize a diverticulum, to do with our gastroenterology colleagues to do a peroperative endoscopy. Fortunately, this lesion was localized on laparoscopy, and we did a laparoscopic jejunal resection and anastomosis, and this is a specimen. If you can see very clearly here, two holes of the diverticulum, and this is the hole from which you can see a leash of vessel inside, from which this was bleeding. So again, two cases which presented quite similarly.
The CT, you should do it definitely with oral contrast. If you don't do it with oral contrast, you can probably miss the diverticular or the diverticular collapse there, so you might miss it. So it's very essential to make sure that it's doing a positive contrast. This is again very important to see the positive contrast there, which gets delineated there very well. So you need to do a CT scan with oral contrast if you are suspecting a diverticular.
Yeah, but Prem, I would just sort of try to qualify it by saying that in case your first impression is a bleed, then a negative contrast probably will show you a better angiometry.
Yes. If you're looking for the first diagnosis is a bleed, then you should not give a positive contrast. You should always use a neutral contrast. Water or mannitol for that point. Even you use, what I'm trying to say is, if you use a positive or a negative contrast, one of the things has to be given there.
Yeah.
Though positive contrast will show it better.
Dr. Singhal, any comments, sir, about these two cases?
But it's absolutely fine that we should keep our eyes and ears open, not take that all bleeds are upper GI bleed, all are from the variceal bleeding or the drug induced, and we should do logical investigation, and we should comprehensively manage the patient so as to get better outcome before it is too late.
Ajay, your comments before I go to the next case.
I think points have been re-stressed again and again that this is a teamwork. Any patient of a GI bleed is a challenge, has to be managed as a team, all the modalities to be available around the clock, and that's how you make a difference in that. It may be a small number that is added to the, you can save these patients by right intervention at the right time.
Absolutely. And again, I will show you a very interesting case. And again, this will, impress upon what Dr. Ajay has just said, that importance of teamwork. So we had this 70-year-old gentleman whose weight was 110 kilograms, hypertension, and his height was 176. BMI was 35, so he was morbidly obese. He presented with the features of intestinal obstruction. CT scan abdomen was done, which showed growth in the rectosigmoid with proximal dilatation. So this was a large bowel obstruction, completely obstructed, and this was actually referred to us by Dr. Ajay Kumar, and they proceeded with a colonoscopy, and what it showed was an obstructed growth at the rectosigmoid junction. Scope could not be negotiated. I think there is a noise in the background. Somebody's, if you can ask them to be mute, please. Okay. Histopathology came as a well-differentiated adenocarcinoma. Now, this is a very tricky situation. This is the colonoscopy picture, completely obstructing growth. So what should be the next step? Dr. Bhalla, since this is a surgical case, I would ask you what should be done next? So you have to unmute yourself.
This patient is an obstructed left-sided lesion, and we have to do something to relieve the obstruction. Now, like you said, laparotomy with colostomy is the traditional sort of option we have, where we can do a laparotomy or even a laparoscopic thing if it's possible, in spite of the distension, to do a colostomy. But that limits our subsequent management options. So what has been, what you're going to show and what has been the practice in our unit has been that, in case it is stentable, and we are very lucky to have very experienced. Hello.
Yeah, you are audible, sir.
Yeah, there's some disturbance on the thing. So in case we have, and we are lucky to have very experienced endoscopists with us, gastroenterologists with us, and who can do a very gentle cannulation of this lesion and then stent it and give us the option of managing this patient subsequently. So right. While the laparotomy with the colostomy would be the way to go traditionally, but if you have the facilities available, you have the option of what the other options, which we will, I'm sure, discuss as we go along.
So for the sake of the audience, what Dr. Bhalla is trying to say that normally, conventionally, this person would require a laparotomy because there is an obstruction. And since there is an obstruction at rectosigmoid, what you need is to remove the tumor and do a stoma. Whether it is an end colostomy or a loop colostomy is a different issue. What happens in an obstructive colon that you end up doing a lot of spillage in the abdomen, which will lead to wound infection. And any wound infection we know can later on lead to hernia. And also, when you do a stoma, you will require a second surgery. So what practically we have done, or which is what is going to happen to the patient, that morbidity of staying in the hospital, having wound infection, having sepsis, having hernia, having second surgery is enormous. So he's suggesting that if you have an experienced gastroenterology team like we have, you can stent this lesion and get away with an obstruction at that point of time, and then do an elective surgery, which can be a single stage surgery without a stoma, and you can do it minimal invasive technique. But I have seen in my little experience that not many gastroenterologists are very comfortable putting in a stent. And I would like to have comments from Dr. Ajay regarding this. What is his impression about putting stents in these kinds of patients?
Well, I think as rightly pointed out earlier, the whole choices are very straightforward. One, you have a traditional system of doing a laparotomy with colostomy, and then you come down again for a second surgery to do a definitive surgery. I mean, if you are not able to resect in the one go, or you would go for a colostomy closure in the second sitting. And the problems associated with it have already been pointed out by Dr. Deep Goyal. But the other option is to do a stent, and that is in a randomized control study that has been shown that not only that it converts the surgery from two-stage surgery to one stage, it also reduces the chances of a anastomosis blowout, infection, and other complications pointed out by that. So we'll always like to prefer to go and put in a stent, which is today you have a very high quality stent, and under good fluoroscopic plus endoscopic supervision, you can do that. As you see in this patient, that this it is a narrow stricture, short segment, but then when we put in a stent, it expanded and the patient opened up, and so the ileus was gone, patient's obstruction was relieved, and then when the patient got stabilized, then surgeons could go in and do a single stage procedure rather than doing a two-stage procedure. Over to you, Deep.
Yeah. So this was very elegantly stented by Dr. Ajay himself, and this is the picture of stent in place. And these are self-expanding stents. They gradually open up and relieve the obstruction, and we normally wait for 48 to 72 hours for the obstruction to completely settle down, and then take up the patients for possible single-stage surgery. And this particular case, we did a robotic low anterior dissection, and you see how precisely in these cases, since he was a morbidly obese patient, it would have been a very, very difficult surgery doing open, especially if we had not stented the patient. Imagine doing a laparotomy in 110 kilograms patient with hypertension and other comorbidities, then having wound infection. He's definitely going to have a hernia and possible sepsis. And here, after stenting, once the obstruction was completely relieved, we were fortunate to go ahead and do a single-stage robotic low anterior dissection with sort of precision without any blood loss, and you are able to identify all the nerves. So I think I will just move with another case.
Deep, can I make just one comment on this?
Please, sir.
See, one of the advantages which you could list into this, enumerate also is that there is a great prognostic implication in that if you have a spill of an obstructed malignant colon on the left side, then you've upstaged your disease.
Right,
if you can do it, the procedure, if they can stent it and then do a resection, then the chances of upstaging come down, and it's good for the patient's overall prognosis.
Perfect. And this is a picture showing the specimen with the stent in place. So take-home message is laparotomy in malignant large bowel obstruction will lead to multiple procedures, high incidence of wound infection, incisional hernia, and loss of work. And as Dr. Bhalla rightly said, we can also add that it can can lead to poor prognosis because of the spillage of the tumor. Endoscopic stenting can avoid all of the above, and procedure can be done laparoscopically or robotically in expert hands. Sir, I would now request Dr. Ajay to show a couple of cases. I will stop sharing my screen and I would invite him to share his screen.
Can you see my screen?
Yes, sir.
Yeah, we can.
Well, friends, thanks, Deep, for presenting such a beautiful cases. They're well managed, and also to discuss the issues which are involved in day-to-day management of some difficult cases. I've tried to put in two different clinical situations here, two different clinical settings. These are day-to-day problems very commonly seen, and let's see that how we were able to manage, or what are the guidelines for that. Here, the first patient I'm presenting is a 45 years old male who had severe upper abdominal pain, epigastric pain, going to back, classically suggestive of pancreatic pain. Patient had associated vomiting, distension, had tachycardia, normotensive, and respiratory rate was around 24. Clinical examination, bowels, abdomen showed mild tenderness, there's a distension, sluggish bowel sounds, but there was no lump, no guarding, no rigidity, and clinically chest was clear. This patient was not alcoholic, he was not diabetic, he was not hypertensive. And with the possible, the way acute abdomen presents in the emergency, at this particular patient, we had a suspicion that could be pancreatitis. We asked for serum and lipase, and the values are in front of you. They were significantly high. The liver function tests, SGOT, SGPT, and bilirubin were also raised, and ultrasound was done. I'm not showing the X-ray, but X-ray was shown, did not show any air fluid levels or did not show any air in the diaphragm. Ultrasound showed bulky pancreas, and there was some peripancreatic fluid collection, but no gallstones were present. CBD could not be clearly seen. So the diagnosis is pretty clear, and I think the one, it is an acute pancreatitis. Diagnosis of acute pancreatitis, we know that 2 out of the 3 criteria, that is classical pain, raised amylase lipase, and morphological evidence, if 2 of the 3 are present, then it is acute pancreatitis. Why I have labeled it as a biliary, just because, not because the patient did not give any history of alcohol, but if you check this, the disturbed liver function test, whenever you have this, then the very high chances that patient has gallstones slipping into the bile duct and causing pancreatitis. Now, on this basis, acute biliary pancreatitis was made, and we had made it a mild pancreatitis because the patient had no organ failure. Patient was managed with IV fluids and painkillers, stabilized over 48 hours, pain settled down, was ready to take oral liquids, and vitals were stable other than tachycardia of around 90 to 96 or so. Now, the questions in this patient that I want to address today, and the way we manage this patient, is one, what is the indication of ERCP in existence of acute biliary pancreatitis? And I can have the surgeon's viewpoints in that what is it that you will do? Will you ask ERCP and when will you ask for it? And the second will be, that's a more of a surgical question, that what is the timing because of cholecystectomy in acute biliary pancreatitis? I'll present that data on that, but let me just ask the surgical colleagues, what is the viewpoint before that? Any one of you, Dr. Kalla, Dr. Deep are there?
Kudeep?
Okay, so sir, these are very, very pertinent questions, and there has been debate going on for longest of years. But today we know that we used to be very liberal with ARCPs in acute pancreatitis when I was being trained. But today we must document that there is a stone which is stuck in the bile duct at this point of time. Then only I would proceed for ERCP, and the method to make sure are either MRCP or doing an endo ultrasound. These two modalities, if any of these modalities confirm that there is a stone in the bile duct, then yes, ERCP is recommended. But if any of the modalities do not confirm and the enzymes are settling, LFT is settling, then I think we do not require ERCP in these cases.
Okay, wonderful, Deep. We'll go for the second question later on. I'll come back to you.
Right, sir.
If you look at the ERCP in acute biliary pancreatitis, there are a number of variables. There was a time when there are two, which everybody used to say, if you have severe acute biliary pancreatitis, go in for ERCP within first 24 to 48 hours. Or the other issue is, other than severity, that is the presence of biliary obstruction or cholangitis. Without going into too much of literature, I'll just say two things. One is, in acute pancreatitis, ERCP is not easy because there is a lot of edema in the duodenum. So whatever decision we take to intervene, we should know that even the best of the endoscopists can fail even to identify the papilla. You can see from this that how edematous these are, and so you will end up as a failed ERCP. Even if you try to fiddle with them, you end up more with complications. And this elegant study showed in a setting of acute pancreatitis, if you fail to do ERCP, your complications and re-interventions are much more as compared to the successful ERCP, and the chances of failure are high. So you need to select your right cases. That is the message. And what is this right cases? Now, there could be three clinical situations. That patient has no clinical lab or radiological evidence of biliary obstruction. Then the answer is no endoscopic intervention. Here, patient may have no cholangitis, but the patient may have obstructive signs of with the raised LFTs or a radiologically showing CBD is dilated. Again, even if there is a stone and there is no cholangitis, earlier were used to be doubtful, but now with the latest data, it is pretty clear, more than one study to show there is no urgent ERCP. I'm talking of the word only urgent. Yes, patient stabilizes, then you will need ERCP. But if the patient has cholangitis, and which is evidenced by fever, leukocytosis, toxemia, which can happen even in acute pancreatitis, there is a need for urgent ERCP, and that's what when you say the diagnosis of cholangitis in setting of acute pancreatitis is not clear, and what Deep has rightly said, that's where endoscopic ultrasound comes into use. And here you can see a stone in this is the bile duct, and this is the stone in the bile duct. And if you find it, you do go in, do the sphincterotomy, and remove the stone and deliver it, and that is the answer to that. So the indication of ERCP in acute pancreatitis is basically only when you have cholangitis. Other than that, there's no indication of urgent ERCP. Yes, if the patient stabilizes and you have to document that there is and you know that there is a stone in the CBD, that is the time when you do it before cholecystectomy. The second issue, earlier on, all surgeons used to be hesitant that during acute pancreatitis, you should be delaying the surgery or cholecystectomy, which is the definitive treatment for this, for about 6 to 8 weeks. But what happens that in 4 weeks, 50% of the patients will come back with a second episode of acute pancreatitis. So it is advised that in the patients in mild acute pancreatitis, you should be operating in the same hospital admission, and this has no significant effect on 6 months mortality. And this is a currently accepted guideline. But the problem is that if you have moderate to severe pancreatitis, then because you have a collections inside, during surgery, you may end up infecting the collections, and and turn the sterile collection into infective. Here you may delay it for about 6 weeks. And those who have severe or unfit for ERCP, we do a sphincterotomy and put a stent and to prevent the risk of recurrent acute biliary pancreatitis. So the American Gastroenterology Association 2018 published clinical guidelines say that the same admission cholecystectomy for mild Gallstone acute pancreatitis. I hope my surgical colleagues, Dr. Bhalla, Dr. Deep, agree on that. What is their inputs on that?
I think these recommendations are very valid, sir. What we also say is that if there's a mild pancreatitis, same admission cholecystectomy. If there is a moderately severe pancreatitis, then we wait for 6 to 8 weeks. The problem really comes is when you have them coming back to you in between for recurrent pancreatitis. And that is a clinical call which sometimes has to be taken. But yes, mild pancreatitis, same admission, cholecystectomy. Severe pancreatitis, interval cholecystectomy.
Any comments from on any of these issues from the Deep or Dr. Prem or Dr. Singhal?
No, I think I agree with you and Dr. Bhalla that, mild pancreatitis and sometimes even moderate pancreatitis where abdominal signs and symptoms are not severe, we end up doing cholecystectomy in the same admissions, and we are bolder, as you rightly said, as time has passed. And we have never regretted it doing it in the same admissions. But severe pancreatitis, we would like to wait.
Absolutely fine.
So with that, I'll go to see, I'm presenting 2 cases of the similar problem. I'll quickly go through the clinical. All my patients are related with the acute abdomen. This young lady, past history of tuberculosis for almost 7 years back, came to emergency with a 3 years history of, patient had a 3 years history of recurrent subacute intestinal obstruction and was admitted this time with the features of subacute obstruction. Patient had a classical distended tender abdomen, and this is our resident in the emergency got this X-ray done. So Dr. Prem is there. We take his help. Dr. Prem,
This is a plain radiography of the abdomen done in an erect position, which actually shows to you multiple dilated small bowel loops, and you can appreciate a lot of multiple air fluid levels all over the place. And then what you see here is characteristically, you don't see the large bowel gas at all. So, and there is no free gas under the dome of the diaphragm. So essentially, it's multiple small bowel loops with air fluid level, which is very much diagnostic of a small bowel obstruction there. There is no perforation, which I can see on this.
And looks like a distal small bowel obstruction.
Looks like a small bowel obstruction more or less because the bowel loops are more or less in the center. I don't see a large bowel, much of the gas in the large bowel.
Distal small bowel is it?
Yeah, small bowel.
Yes. So, as usual, I like to point out that this is what we ask for. In most of these patients, Dr. Prem, you can tell us the findings. At the same time, you can also tell us why it is advantageous to do a CT scan at this stage and what precautions to be taken while doing a CT in this.
We need CT scan is the modality of choice in patients with acute abdominal conditions because clinically you may not get a lot of findings which is there. And this is the CT abdomen this is the axial scan on the right hand side and the coronal picture on the left hand side. And you can see the whole abdomen is distended and the small bowel loop is dilated. You can see here a neutral contrast which has been given, which is probably mannitol or water even can be given. And this has distended the dilated small bowel loops. And you can very much appreciate in the coronal view all the extent of all the small bowel loops which is there. And this image is not showing you till the IC junction. Distally is an intramural wall thickening there in the right iliac fossa region, which you can see it here also. And there are no lymphadenopathy that is seen in this, and there are no free fluid seen in this particular image. So that essentially it is suggestive of intraluminal, intra-wall thickening there in the distal small bowel loop, causing proximal dilatation of the small bowel extensively there. I can't see any lymph nodes with necrosis, which would have helped me in giving a diagnosis of a possible tuberculosis there. But though patient has a previous history, I don't see any calcified lymph nodes either. So essentially, it looks like a distal small bowel obstruction, which is presenting as intestinal obstruction.
Dr. Prem, when you ask for a CT, you ask what are this thing? Do you give contrast here or not? What is the usual policy here?
Usually we prefer in intestinal obstruction case, we prefer to give a oral contrast so that we are able to delineate the obstruction and to some extent add value to the type of obstruction that we can see. But quite often in these patients who come with such intestinal obstructions, they are all usually vomiting a lot. So they already have an NG tube inside. So there is a challenge there in giving oral contrast, or for that matter, any contrast orally. But we do try and give it through the NG tube and things like that. That definitely adds value to it. But in an obstructed system, you give it or you don't give it, you can really still show the obstruction that is there.
So CT in an acute obstruction gives us number of informations. One, it helps you in making the diagnosis of the obstruction per se. Two, it tells you the site of obstruction. Thirdly, it also helps you in talking about cause of obstruction. That is there a tumor, stricture, and as Dr. Prem pointed out, if there are associated necrotic lymph nodes, you can say it is even tubercular and so on. And fourthly, it also helps you in looking at the complications of obstruction, if there is any ischemic bowel taking place, if there is any perforation, and so on. So this becomes one of the most important investigations for a patient, even when we are suspecting it's a obstruction case. Now, this patient was managed with the classical typical treatment of acute subacute obstruction, that is nil orally, IV fluids, Ryle's tube aspiration, and of course we give a parenteral nutrition to that. And this obstruction was relieved within about 48 hours. Normally, get relieved in about 3 to 4 days, then we look for emergency surgery. But if it gets relieved, then even surgical colleagues will agree that first we define the level of obstruction, site of obstruction, cause of obstruction, and then take a call when to operate. Do you have the concurrence of the surgical colleagues on that issue?
Yes, sir. I think that's a very well made point. That in case most of them do settle down with what classical prescription that we give of grip and suction. You just remove the distension in the bowel and the obstruction is released. And God forbid, if the patient does require a procedure afterwards, if there is no distension, then that procedure can even be done laparoscopically. I think the one rider is that in case the patient has pain associated with obstruction, then we would not like to wait for more than 24 hours. Classically, they say, don't let the painful obstruction see 2 sunrises or 2 sunsets. But if there is no pain, if it is just obstruction, one would just go, like you very rightly said, we decompress the gut and usually the obstruction will settle down.
So this is basically decisions made on a day-to-day clinical assessment of the patient. And secondly, also to assess the patient psychologically, what is their mental state and what do they opt for. At the same time, you need to guide them through that and take a decision. This patient settled down within 48 hours. And after some couple of days, we did the colonoscopy and we found that this is a stricture here in the ileus at the terminal ileum. And this was a short stricture. And we went ahead and this was about terminal ileal stricture about 10 centimeters from the ileocecal junction. And this is the area of narrowing that you can see here. So we decided to put in a balloon. This is called CRE balloon, which we, under endoscopic guidance, we could dilate it and the scope could be pushed beyond that. And before that, the scope did not go in, but after the dilatation, we could do. We could take the biopsies after that. And the other thing is that when you do it, we have to select our cases. If we find on a CT that there are multiple strictures, there are too long strictures, or we find a big ulcerations around here, then we don't like to do dilatation because we increase the chances of complications. And this patient went into graded dilatation up to 18 millimeter for 1 minute. There were no immediate or delayed complications. Patient came to us after 1 year of follow-up. There is no recurrence of symptoms, and patient had improved colonoscopic findings, and so on. And a similar case, I'll come back to some data on that, but this was a older age, 66 years old, who had ATP almost 10 years back, and also had a similar history of subacute obstruction, almost presented with the same picture, X-ray. Dr. Prem will agree this is more or less the same, but the bowel loose were dilated more than the previous one as well, but almost similar picture. Again, the same patient, but here, Dr. Prem, will you agree with me that this patient had matted lymph nodes? And of course, it was a more closer to the ileocecal junction. You can see here the thickened walls and so on. Again, this is a patient had a multiple hospital admissions in the different hospitals. This was the first admission with us. So we went ahead and did once he settled down, we found a fibroptic stricture at the mid-ileum. It's the same short segment. And this is what you will notice here, that you see on colonoscopy, in the terminal ileoscopy, you see a narrowed area. That scope does not go. This is a guide wire going in. Over the guide wire, you push in a balloon and you dilate it. Almost the same diameter balloon which we used in the previous patient, and our scope could be negotiated beyond that. So this patient also dilatation up to 18 millimeter, no complications. Actually, now this patient has come to us almost even 2 years later. There's no recurrence of symptoms, and there's no improved colonoscopic findings on follow-up. Just to briefly tell you that these two patients had a history of tuberculosis and had ATT in the past. Now, this was a study done by Dr. Anand from center where I passed out at the GB Pant Hospital, that 70% of patients with intestinal tuberculosis will recover only on anti-tubercular treatment, while in the remaining 30%, and they will show subsequently the chance of symptoms of obstruction. And sometimes that also comes down with passage of time. But it is not a failure of medical therapy, but these are the consequences of the past tuberculosis which can keep on causing symptoms. Earlier on, the only treatment we had was a surgical resection. But this was a Dick Kozarek, when he published this study almost 2014, with balloon dilatation of benign small bowel strictures using enteroscopy, and from 5 years review, and they have shown that balloon dilatation is a safe and feasible alternative to surgery in selected cases. As I said, too long strictures, active ulcerations, you should not be taking them. Patient with any complications or perforation in the past or anything, collections around that, you should not take them for balloon dilatation. And good long-term outcomes are available. In these two patients, we could dilate them only once, dilated them only once, and they have been symptom-free for more than 1 year. But then some patients may require more than one sitting. And the short-term success rate is obviously very good. The long-term success rate also is extremely good, almost 80 to 90%. And there is a usual complication which can happen, which is also a minor complication of the bleeding, but there is no perforations reported if you select the right case. And that is the most important part. So friends, message from these two cases is that endoscopic balloon dilatation is a safe and effective modality of treating benign bowel strictures, small bowel strictures, with short and long-term results. I have shown here mainly cases of tuberculosis, but there is a huge data available even on the patient with Crohn's disease. It usually prevents emergency surgery, and it may prevent completely the surgery, but even if not, it can significantly delay it if they keep on coming repeatedly for dilatations. For isolated intestinal fibrostenotic benign stricture of less than 5 centimeters without fistulization, endoscopic biliary dilatation should be considered first-line therapy. And that's the, I can take up if there are any panelist questions or discussion, any comments. Otherwise, we can go on to, we have time for another case which Dr. Deep can take over.
First of all, I think I would agree with you completely, sir. In a subset of patients with intestinal obstruction who have a stenotic stricture in terminal ileum, there is a role of endoscopic balloon dilatation, no question about it. And if the surgery can be avoided, it's always best in the interest of the patient. And that is where also, once again, to emphasize the role of team, how multiple minds are working for a particular patient to give them the best, which is available in-house as a team. So that again emphasizes. Any comments from Dr. Bhalla or Dr. Singhal, sir?
Okay, fine, sir. It is a nice presentation where we can see that there is a comprehensive management, that we can have good results in safe hands and patient gets a better outcome.
The reality is that we also take all these liberties of doing all this because we always have surgeons on our back. That we know that if we are in a complication or in this thing, we can always rely upon them to take care.
That feeling is very mutual, sir.
So I will quickly move on to...
I'd like to add something.
Yes, Dr. Prem. Prem?
Prem has muted himself.
Unmute yourself, Prem. Unmute yourself.
Okay. I'd like to add here a bit of it that usually these patients, when they are not presenting in an acute abdominal obstruction scenario, unlike this, when they are presenting in between these obstructive features, we should plan and do a CT enterography. A CT enterography is a very specialized CT process. We have a separate protocol for it, in which we give the contrast the negative contrast in a very systematic manner. So that delineates all the areas of narrowing and strictures and these things. So CT enterography is a very good procedure which we should do it when the patient is not presenting in acute abdominal obstruction.
Point well, yeah.
There are certain questions. Deep, should we take it right now or at the end of the presentations?
Sir, is presentation ke baad kar lete hain, sir.
We will do that. We will have time.
Okay. So these are two cases of similar disease, but you will see how they were managed in different way. Again, emphasizing the team effort and the impact of the team. 61-year-old female who presented to us with pain in the upper abdomen since 10 days, multiple episodes of vomiting, 5 days, obstipation for 3 days. Ultrasound abdomen shows thickened edematous gallbladder wall with pericholecystic edema. Ultrasound abdomen again was same thing as we have said. And CT abdomen, before this we did an X-ray abdomen which showed intestinal obstruction, something similar to what Dr. Ajay has shown. And CT scan abdomen was done which showed distended gallbladder, thick wall with air and calculi within the lumen. Also we found a hyperdensity which was possibly calculus in the proximal jejunal loops causing small bowel obstruction and a small calculus within the lumen of the second part of the duodenum. So see, this is a CT scan which is very clearly showing air in the gallbladder, depicting that there is some sort of fistulation between the gallbladder and the small bowel. And that is where the stone would, pass on from there. So always, whenever we see these kind of cases, see this pneumobilia, and this is the stone in the jejunum, if you can see here. So this is a case of gallstone ileus, not a very common diagnosis. Sometimes you see them in row, and sometimes you don't see them for years and years together. So this particular case, since abdomen was very, very distended, we went ahead and did an exploratory laparotomy And by making an enterotomy, we were able to retrieve the stones in the gallbladder. Most of the times, the temptation is too high to do a cholecystectomy. But in this particular case, what we did is to do a cholecystostomy. That means we made a hole in the gallbladder because there were other stones in the gallbladder as well. And we did not do a cholecystectomy because that is what the recommendation is, to do a cholecystectomy on a later date. If you see, this is the dilatation and this is the stone stuck in the jejunum. If you see here, this is a small video showing small bowel outside, and from two hands, one from surgeon, one from assistant, we are holding the stone and making an enterotomy, a liberal enterotomy, because it's a very large stone. And as you will see, the stone is being delivered out. Such a large stone. It was, if I remember correctly, around 7 centimeters stone in the jejunum. And also there were some other stones of a smaller size. And so this is a diagrammatic representation how stones in the gallbladder, and while there is a fistulization between the gallbladder and the duodenum, how the stones passes, and normally they get stuck in terminal ileum, but since this was a very huge stone, this stone got stuck in the jejunum itself. So take-home message from this case is gallstone ileus is a rare form of small bowel obstruction. This is most of the time there is a cholecystoenteric fistula, and stone size normally is more than 2.5 centimeter, and commonest obstruction site is distal ileum. And one must avoid temptation of doing cholecystectomy at the same time. One must stage these procedures to avoid morbidity. In the same line, I have another case. Is a 69-year-old male presented with obstruction and vomiting. Only feature here was that this patient was a cardiac patient. He had a cardiac myopathy, and his ejection fraction was 25%. And CT scan done shows a large stone in the first part of the duodenum, obstructing the duodenum and presenting like a gastric outlet obstruction. So obviously the first thing which comes to mind is to do surgery in these cases. But this patient, as I said, had a dilated cardiomyopathy, ejection fraction was 25%. So we discussed this case with our gastroenterology. We planned to do an endoscopic procedure for this gentleman. Unfortunately, when endoscopy was being done, he had seizures and we had to abandon the procedure. Patient was resuscitated, neurology opinion was sought, some investigations were done for getting neurologic clearance, and a repeat endoscopy was done with lithotripsy and retrieval of stones. And these are the pictures of endoscopy. As you will see that this is the Dormier basket. Such a large stone was broken by lithotripter and then extracted from D1. So again, this is endoscopy picture, film, showing a stone in the D1 causing obstruction. This stone, it's bulging into the pylorus. That's the pyloric opening, and we are now into the D1. Such a large stone causing complete obstruction of D1. And as you will see here, we're first trying to remove it by Dormier basket, trying to negotiate the basket around the stone. Lithotripter being used to cut the stone. It emphasizes the importance of teamwork, discussing the cases, trying to give best to a particular patient, and also highly skilled team with right instrumentation available in the department. And this is how after removing D1 was completely clear. So again, take-home messages, endoscopy is a very good alternative in selected cases, especially when the stones are in proximal small intestine or patient is a high risk or unfit for surgery. So with this, I would end my presentation, and I have certain questions from the audience which I would pose to the expert panelists. What are the common complications of intestinal obstruction? Maybe Dr. Bhalla can take that question.
So the intestinal obstructions, generally, if you divide it very broadly, it can be of two types. One is a simple obstruction, and one is a strangulating obstruction. Now, the simple obstruction usually, thankfully, is not so complicated. It does have fluid electrolyte imbalances because of the high nasogastric and the intestinal aspirates, but these can be looked after quite well, conservatively. Then there are situations where you have strangulating obstructions, and those are the ones which cause a lot of problem because of ischemia, because of a dilated bowel causing ischemia, because of twisting and volvulus. These patients can sometimes have localized gangrene and perforations, and then all the complications of perforated intestine sets in, peritonitis, sepsis, and these can be really quite a challenge to treat. So, right, the spectrum is right there. You can have a simple obstruction, not very many complications, just fluid and electrolytes, and then you have these strangulating obstructions where you can have peritonitis and sepsis.
So next question I would ask Dr. Singhal to answer, please. Sir, what are the atypical symptoms of diaphragmatic hernia or hiatus hernia? Giant diaphragmatic hernia or hiatus hernia?
The thing is, patient could have very non-specific symptoms. Patient could have some abdominal heaviness, some after the food there is some belching, some uneasiness. They can't feel to lie down, and if they lie down, they will have more problems. They could have some heartburns, and they would be, quite disturbed by these symptoms, and they keep on going to different doctors, keep on popping pills, and unless they are diagnosed and if they are able to take some precautions, if they don't settle, then surgical correction is done.
Sometimes these patient symptoms can be confused with the cardiac symptoms.
Yes.
They have restlessness, discomfort in the chest, especially in the left side. And a lot of times we see that these patients have been completely evaluated for cardiac diseases, and then later on we find on endoscopy that they have diaphragmatic hernia or hiatus hernia.
On echo, they also sometimes report focal sort of wall motion abnormalities in the heart. And these get corrected after the hernia is tackled.
So next question is for Dr. Ajay. Sir, can we do ERCP more than once before lap cholecystectomy? If yes, what is the interval between two ERCP settings? I think what he means is that if you are not able to successfully remove stones in the first sitting.
See, yes, we can do theoretically, but then you have to know for what purpose you are doing. If it is a large stone, you are not able to extract, or you are not able to, there's a severe cholangitis, then yes, then you have to make the patient stabilize. And you can do 1, 2, 3. That is not the limit. It's a question of the indication, whether it is there or not there. The second question of the gap, if it's a straightforward, what is our regular policy? Patient comes with a gallstone, with a CBD stone. Patient may have jaundice. We will do the ERCP, clear the CBD, and we will request the surgeon to operate next day itself. And our surgeons are pretty enthusiastic about that. They are pretty cooperative. Otherwise, if you don't do that, what are the drawbacks? The drawbacks is a fresh stone can pass on into the bile duct. 2, if you, gallbladder is not a healthy gallbladder, and you have injected something from below. So you can introduce infection in the gallbladder, and a simple gallbladder stone can be converted into empyema. And that makes the surgery also more problematic. So that is the ideal thing. But yes, there are situations that you have to postpone when you have a severe cholangitis, you have very deep jaundice, that you will like the things to stabilize, patient to general this thing. In such situations, we always like to put in a stent, plastic stent in the bile duct temporarily, and till the surgery is done. And it can be done any day when the patient's overall condition is stable. And after the surgery is done, then we'll go in and remove the stent permanently, and also make sure that the bile duct is clear.
Thank you, sir. Dr. Prem, I think you will take this question. If patient is unwell after cholecystectomy and ultrasound shows ascites, how do we differentiate between bowel injury versus bile injury? Should we go for CT scan first or should we do some other investigation?
CT will still stand as the modality of choice in these patients because it will give us an assessment about the collection, where exactly is the collection and how much is the collection. Yes, of course, on CT, I would not be able to differentiate between a bile, blood, or the leak from a small bowel or bowel unless I give a oral contrast. If I give a oral contrast CT and then I can demonstrate the leak of oral contrast into the peritoneal cavity, I can very confidently say that there is a bowel injury. But if there is no leak which I can demonstrate, I would not be able to differentiate between these three. Is it blood? Of course, sometimes I can give an opinion that it will be possibly blood because of increased attenuation of the collection that is there. So CT would be the modality of choice.
Complementary to any imaging, I think also would be to just aspirate that fluid and see what kind of fluid we are dealing with. If it's a pure bile, it is likely from
the imaging won't give that answer. It's only an aspiration of the contents that will give it.
Dr. Ajay, would you like to say anything, sir, for this?
No, I think that's absolutely.
So next question is for you, sir. In a patient with ileocecal Crohn's or small bowel Crohn's with mild stricture, what would you recommend, Dr. Ajay, sir?
You see, normally there is what we like to know whether this stricture is due to edema or due to fibrosis. And there could be a combination of the two elements. If the symptoms settle down with a medical treatment, then we don't like to intervene in these patients. But if the symptoms of obstruction persist, even after we have a clinical and a biochemical remission, that is the time we need to think of intervention. And I think the intervention is the same as what we had just not discussed in those two cases of tuberculosis. I did mention in the last that even in a short Crohn's stricture, we can use that. But again, it should not be long. It should not be multiple. It should not be having active ulcerations. And should not have fistulization. Otherwise, we can use that. Otherwise, surgeons come to our help. The problem in Crohn's disease is it is not other than ileocecal, it can be multiple places. So you have to actually evaluate the whole area very carefully.
I'd like to add here what I mentioned about CT enterography. CT enterography would be a better tool to pick up those skip lesions, as Dr. Ajay has said. So if you have multiple strictures and all, that is CT enterography will pick it up much better than any other.
So last question is for the day. What are the common challenges faced by clinician while managing the case of obscure GI bleed? Dr. Bhalla, sir.
Well, the obvious challenge is to find the source of the bleed. That can be a big challenge. Now, we have come on, when I was training, we used to be told that in case you can't find a cause of the bleed, then you operate and then you do a right hemicolectomy. But with all the investigations, with all the endoscopic procedures which are now possible, with the hybrid procedures, combining laparoscopy with endoscopy, such events are now rare. And more often than not, we can find the cause of the bleed, which is the biggest challenge.
Thank you very much, sir. I think with this, we will close the session. Any comments from any of the panelists before we go away? I think to conclude, then I would say that, these challenging cases which we see every day in our practice, wherever we are, what is required is a open mind and team approach. I think one should not hesitate taking help from our colleagues, because I think everybody's aim is that the patient should go back safe and possibly cured from the ailment. And I think when multiple minds are working towards the same direction, it is likely that the result is going to be better. And this is what we practice in our hospital, in our department. all of us together, we put our minds together. We are like, we may fight, we may argue over a particular patient, but the moment we walk away from the patient, we are, sort of sitting together having a cup of coffee. I can't say here in India during the hospital hours, but yes, this is what I think we practice, and we think that is the way forward. And we would request all our colleagues and the audience to follow the same. Always take help of colleagues and specialists in treating your patients. Thank you very much. With this, I would close this session, and also I would thank once again Docplexus for giving us this opportunity, and all the expert panelists and my co-moderator Dr. Ajay. Thank you very much. Stay safe, and we will meet soon again for another interesting webinar. Thank you very much.
Thank you. Thank you.